Hi, this is Gregg Stone from the Mount Sinai Heart Health System, and it's a pleasure today to speak to you about vulnerable plaque, diagnostic, and treatment options. These are my disclosures. So first, let's start by saying that we've made tremendous progress in the treatment of patients with cardiovascular disease. This was an article that was published a few years ago by Betsy Nabel and Eugene Brunwald in the New England Journal, looking at the decline in deaths from cardiovascular disease in relationship to scientific advances. And the first thing you can see is that we used to be having around 400 to 500 deaths per 100,000 population due to heart disease. And in the United States, that has markedly decreased to about 2010 to about 100, so about an 80% decrease. And they link this to a lot of important scientific advances, including revascularization therapies with both PCI and bypass surgery, statin treatment and other preventative therapies for atherosclerosis, treatment of acute myocardial infarction, such as with primary PCI. So we've made tremendous advances in both the primary prevention, secondary treatment, and secondary prevention of heart disease. But that being said, we're not done yet, because cardiovascular disease still is the #1 cause of death in the developed world, responsible for almost 1 in 3 people dying in the entire world, dying of cardiovascular disease. So about 18 million deaths per year. And in fact, if you look at some of the most recent vital statistics from the United States, we actually have reached a plateau in cardiovascular mortality. I showed you the great curves up to 2010, but since that time, we've really plateaued. And in fact, there's a little bit of a suggestion that we may actually be increasing in cardiovascular mortality in the last few years. So what we need to do is focus on both treating patients with cardiovascular disease, especially the end-stage manifestation, which is acute myocardial infarction, and we have to do even a better job preventing it. Now, we know the pathophysiology of acute myocardial infarction in most cases is a ruptured plaque with a occlusive thrombus. And we know from 23 randomized trials of primary PCI versus thrombolytic therapy that we've gotten pretty good at treating this disease with an invasive interventional approach. We can reduce mortality, reinfarction, recurrent ischemia, length of hospital stay, we improve LV function, et cetera. On the other hand, we don't do such a great job with primary prevention, in particular when we focus on revascularization of patients with stable coronary disease. Most patients with, quote, heart disease present with symptoms of stable coronary disease, such as angina or exercise limitation. And here we have a very different pathology. Rather than a thin cap fibroatheroma, we have more pathologic intimal thickening, and I'll talk more about this in a few minutes. And most studies to date have shown that if we revascularize patients with stable coronary disease, we can improve symptoms and quality of life, but we don't prevent heart attacks and we don't prevent cardiac death. Most recently, this was really shown in the ischemia trial, which I was one of the principal investigators. And this was a large-scale trial of 57 to 5,800 patients with stable ischemic heart disease and with moderate to severe ischemia. And revascularization in these patients compared to just ongoing medical therapy was ineffective at preventing cardiovascular death or myocardial infarction. Now, we do know that when we take patients with mild or diffuse coronary disease, they do have a risk of suddenly progressing to an acute coronary syndrome, either unstable angina or myocardial infarction or even sudden death. And this happens from angiographically appearing mild plaques, which then apparently suddenly progress. This was perhaps best pointed out in the early 2000s from the NHLBI dynamic registry of patients who had undergone catheterization. About 6% developed an unstable, rapidly progressive plaque within 1 year. And these are most commonly from angiographically mild plaques. And these have been called vulnerable plaques. These are plaques that typically don't produce ischemia, but place the patient at risk for sudden death and acute coronary syndromes. And we've learned from pathologic studies that these types of plaques that cause MI and sudden death are most commonly what are called thin cap fibroatheromas. And that is there's a lipid-rich necrotic core consisting of dead cells, cholesterol esters, which is separated from the lumen by a very thin fibrous cap. And this is a very metabolically active lesion. In the setting of systemic inflammation, this cap gets infiltrated with macrophages and matrix metalloproteinases and other compounds that will digest that cap and lead to rupture of the fibrous cap. And that will expose the underlying necrotic core, which is very prothrombotic. It releases tissue factor and other prothrombotic compounds. And that can lead to a sudden development of a thrombosis on what was a non-occlusive plaque. So this is often made the analogy that this is like a volcano waiting to happen. And as you know, when you see a volcano, you don't know what's going on behind the surface. Well, this is actually a sagittal section of a vulnerable plaque. And you can see this well-formed necrotic core, which is lipid-rich, cholesterol esters, barely being held from breaking through to the surface by this thin fibrous cap, just like a volcano. And you know what happens with these metabolically active volcanoes. Now, unfortunately, it's not quite this simple. There are other morphologies that can cause acute myocardial infarction and sudden death. While plaque ruptures probably cause 60 or 70% of them, there's a substantial number that are caused by plaque erosions, which are glycoprotein-rich plaques that actually don't rupture, but they can have a thrombus form on top of them because of an eroded surface. And then a small percentage of patients might be these calcific nodules that cause enough turbulence and platelet activation to lead to thrombotic occlusion. So can we detect vulnerable plaque? And if so, can we treat it? Well, there have been both candidate non-invasive and invasive diagnostic techniques. And I'm going to speak mostly about the invasive techniques because that's been my particular area of research. But the non-invasive techniques are very important because they could potentially be used for general population screening. And at the top of the list of these is multi-detector CT or CT angiography. But there's been a lot of work also done with magnetic resonance imaging or angiography, with or without contrast media, with agents to detect inflammation or neoangiogenesis or oxidation-rich lesions and thrombosis, such as monoclonal antibodies. There's been other nuclear imaging tests, such as with SPECT or with PECT, that have been able to detect other matrix metalloproteinases or VCAM or annexin, CD40 ligands, other components of the so-called vulnerable plaque. And then there's also near-infrared imaging as well. But the most of the greatest attention has been paid to multi-detector CT or CTA, which of course is very widespread. And the hallmarks of this are when you see plaques that are low attenuation, but positive remodeling. And they're usually moderate in severity, so they're not ischemia producing. So these patients are often symptomatic. There are other signs as well, such as the napkin ring sign. And when you see these low attenuation, positive remodeling plaques, the seminal work, which was done by Jaganarula and Motoyama and their colleagues, have shown that these types of plaques place patients at risk for acute coronary syndromes. And this can be a risk of anywhere from about 2 to 5-fold, depending on whether 1 or 2 high-risk plaque features are present. So if you take a patient like this, a high-risk plaque and a proximal LAD, it's about a 40 to 50% stenosis, but it's got low attenuation. You can see it's positive remodeled, and there is what's called a napkin ring sign. You can see the SPECT is negative. So this is not an ischemia-producing lesion, but nonetheless, within 1 year, this caused an ST segment elevation myocardial infarction right at the site of this lesion. Now, when we look at intravascular imaging, we actually have a higher signal-to-noise ratio to take advantage of because we can put an imaging transducer right next to the plaques in the coronary tree. And there have been 4 basically FDA-approved imaging modalities which can be useful to detect the morphologic and or chemical characteristics of vulnerable plaque. That's grayscale intravascular ultrasound, which relies on a dynamic range imaging of ultrasound parameters of a plaque to detect the grayscale characteristics of the plaque. If you add radiofrequency imaging to grayscale, you get radiofrequency IVUS, and you can color code the plaque components, as you can see here. We can get much higher frequency resolution by, instead of using ultrasound, by using light, particularly optical coherence tomography. And this can give you resolutions of around 10 to 20 microns compared to about 150 microns with ultrasound. And it's the only technique that actually has the resolution to be able to measure fibrous cap thickness. And then finally, there is near spectroscopy, near infrared spectroscopy, which is the most accurate technique to actually detecting lipid. And these are all FDA-approved techniques. And you can see with NIRS, yellow is lipid and red is not lipid. So if we start with virtual histology, that's radiofrequency IVUS, this has been extensively studied. And based on the morphology of these lesions, you can characterize them to either being fibrotic, fibrocalcific, pathologic intimal thickening. Those are what we would be considered to be the stable phenotypes. Then you could have atheromas, and fibroatheromas, which is the red plaque, are the necrotic core. That's the lipid deposition. And if there's separation of the fibroatheroma by green fibrous or fibrofatty tissue, that's called a thick cap fibroatheroma. If you don't see such a cap, that's called a VH, virtual histology, thin cap fibroatheroma. And these are the ones that are presumed to be at the most high risk, although by not being able to see the cap with IVUS, it really just means it's less than 150 microns thick, where we really think that most thin plaques, most thin caps are really less than 65 microns thick. Nonetheless, we tested this in the first large-scale prospective multimodality imaging natural history study of patients with coronary disease. And this was called the Prospect Study, which was published in 2011 in the New England Journal. And we took 700 patients with acute coronary syndromes, and they had all their culprit lesions treated. Those were the lesions causing the ACS, such as ruptured or thrombotic plaques, as well as other severe stenoses. And then once that was successful, they were formally enrolled in the study, and they went 3-vessel imaging. And they had angiography performed of the entire coronary tree, where we did QCA and measured every single millimeter. And they also had 3-vessel intravascular ultrasound grayscale and radiofrequency virtual histology. And so we looked at basically every half millimeter of the coronary tree with very detailed imaging. Based on this, we prospectively characterized over 3,000 lesions, and then we followed them for up to 5 years to look at the outcomes of the patients. And then based on follow-up angiography, we adjudicated whether the problems that occurred at original lesions with different types of characteristics. And our hypothesis was that the VH TICFAs were going to be the ones that were at highest risk. So this is what we found when we followed these 697 patients with acute coronary syndromes. Over 3 years, 20% of them, or about 1 in 5, developed an acute coronary syndrome. Now that problem, based on angiography, about half of the time arose from one of the originally treated lesions. Those are what we call the culprit lesions. And that could have been from stent restenosis or stent thrombosis. But about half the time as well, they arose from untreated non-culprit lesions. And these were atherosclerotic plaques that appeared angiographically very mild. In about 2% of the patients, they had an event, but most of these were sudden deaths, so we didn't have an angiogram, so we couldn't tell where the event came from. Now, when we looked at a multivariable predictors of non-culprit lesion-related events, what were those plaques like at baseline that caused the problem? We found out that even though they appeared angiographically mild, they had a lot of plaque burden. They actually, and if they had plaque burden greater than 70%, that with a multivariable hazard ratio of 5-fold predicted a future major adverse cardiac event arising from that individual lesion. The second individual predictive factor was a VH TICFA. So the hypothesis did hold. That placed those lesions at 3.35 in increased risk. And the third predictive factor was a small minimal luminal area. And again, these were mild appearing lesions. So plaque burden was the most powerful predictive factor. And if you took those 3 factors, high plaque burden, small MLA, or a TICFA, thin cap fibroatheroma, you had 1,650 lesions with none of those characteristics. And in a median 3.4-year follow-up, the MACE rate was 0.3%, incredibly low. Those were very stable plaques. If you had 1, 2, and 3 of those characteristics, on the other hand, you would then identify lesions with a 10 to 20% risk of developing into a MACE within 3 years. So the first thing is, if you don't have those characteristics, that's fantastic. That's almost the best deferral tool ever. And that you can really reassure a patient that those lesions are not at risk. But if you do have 2 or 3 of those high-risk characteristics, now you've got a 1 in 10 to 1 in 5 chance of that particular lesion causing either a cardiac death or myocardial infarction, or rupturing to cause unstable angina or severe progressive angina. And plaque burden, as I mentioned, was the #1 predictive variable. And again, it was really an exponential curve. There were thousands of plaques with less than 40% stenosis, and not a single one of them caused an event. But when you got up to greater than 60, and then particularly greater than 70, those were the high-risk plaques. And overall, these plaques that caused an event had a baseline diameter stenosis of 32% by angiography. So these are very mild appearing, and you just can't tell how much plaque is there. So they've got a lot of plaque, but they're very mild appearing. So we really exploded the myth in Prospect in that vulnerable plaques are not mild plaques. In fact, they are severe plaques. They just look angiographically mild. So it's very important that we stop relying on the angiogram and we use either a non-invasive or invasive imaging test, because the angiogram only shows the lumen. We need to know what's in the wall of the artery. But it's more than just knowing how much plaque there is, because this is all the high risk, this is all the large plaque burden plaques in Prospect, all of the ones with a plaque burden greater than 70%. And you can see that if they were greater than 70% and a TICFA, now you had a 16% risk of having an event at about 3 years. If it was a thick cap fibroatheroma and a large plaque burden plaque, this was intermediate risk, and it had an 8.7% risk. And if it was a garden variety plaque without a fibroatheroma, then you can see that wasn't risky at all, even if it had a plaque burden of greater than 70%. So we need to know the composition of the plaque as well as its size. Now, another way to get at the composition of the plaque, which is an easier technique to apply than virtual histology, is near-infrared spectroscopy. And this is not an imaging technique, but it's a spectroscopic technique that looks at tissue and can very accurately identify cholesterol and cholesterol esters according to the reflection of light that's sent out from a transducer and reflected back from a particular plaque. And so here, for example, you have an autopsy specimen, and here you can see a patient that's got 2 necrotic cores, and that turns yellow. Here's a patient with just pathologic, a section of the same artery with just pathologic interval thickening. It's red. Here's a second part of the same artery that's got 2 necrotic cores, and it's yellow, and another area that looks, just again, mild plaquing without a fibroatheroma, and it's red. And so this was approved by the FDA as actually the most accurate spectroscopic technique to identify any sort of tissue type in the body. So the utility of this technique was tested in a prospective study called the lipid-rich plaque study. And they performed near IVUS, near-infrared spectroscopy with grayscale intravascular ultrasound in 1,271 patients with a variety of different coronary syndromes, from stabilized STEMI all the way to stable coronary disease. And they looked at the 2-year rate of MACE, again, according to the lesion types. And you can see they found that about an equal number of these adverse events over 2 years were caused by non-culprit lesions compared with previous treated culprit lesions. And when they looked at to see whether or not this lipid detection could identify those lesions that were likely to cause a MACE event using a similar methodology that we did in Prospect, if there was greater than 40% lipid, then those plaques had a hazard ratio of about 4.22 being more likely to cause a MACE event. And in a multivariable analysis, you could see large lipid burden as well as large plaque burden, and in addition to a small MLA, were very predictive of lesion level events. So here is, for example, a circumflex artery that was treated medically, and you can see this moderate stenosis proximally, very mild stenosis more distally. And when they did intravascular ultrasound, you could see the plaque burden was moderate. It was about 62%. But here you could see one particular area had a very high-rich yellow spot, 472 measurement, which is 47% lipid. And what happened exactly at that spot? You could see 1 year later, the patient ruptured a plaque and came in with an unstable angina with a subtotal stenosis. If you looked at a patient level, any patients that had one or more of these plaques also had a double the risk of having an adverse event. So both on a plaque level and on a lesion level, finding lipid-rich plaques predict future acute coronary syndromes. So we have been working now for better than 7 years to actually validate this and take this to the next level with somewhat more robust methodology in a study called Prospect 2. And here we're taking 900 patients with acute coronary syndromes, where once again, after treatment of culprit lesions, we're performing 3-vessel, NIRS, and IVUS. But what's different than in the LRP study is that we are prospectively characterizing every single plaque, and then we're following them longitudinally to determine the individual plaque characteristics that place these patients at high risk. And we're very excited that enrollment closed in December of 2018 with 901 patients, and we'll be presenting this in just a few days at TCT 2020 as a late-breaking trial. So we hope you'll come watch this. And then, so the question is now, can we identify vulnerable plaque? And the answer is yes. Using grayscale IVUS, radiofrequency IVUS, and from the LRP study, near-infrared spectroscopy, and even possibly OCT, we can identify plaques that place patients at risk for future adverse cardiovascular events. So the question, though, is once we find these plaques, since they're angiographically mild and they usually don't cause ischemia, what should we do about them? So here, for example, from a study called SCAPUS, which is 30,000 people in Sweden of mid-age undergoing just routine CT surveillance, here's a 61-year-old woman, previous smoker, otherwise healthy. And her CT showed a proximal LAD with what looks like a vulnerable plaque. It's a low Hounsfield unit. It's positively remodeled. So actually, they recommended that she undergo angiography. And here's the plaque. It's a 30% stenosis in the proximal LAD. And the IFR was normal, so it's not an ischemia-producing lesion. And they went ahead and did NIRS IVUS. And you can see this is a lipid-rich plaque with a maximum amount of lipid of 51% lipid. And when you look here, there's a lot of plaque burden, it's 74%. So for most of our data, assuming Prospect 2 confirms this, we would think that this patient would probably have about a 1 in 5 chance within a few years of having an adverse event. But the patient's already on a statin. Should we stent this? Should we put the patient on a PCSK9 inhibitor? What should we do? Well, we don't really know. We know that one of the ways that statins and PCSK9 inhibitors do work and do reduce the risk of cardiovascular death and MI is by stabilizing vulnerable plaque. And statins have been actually shown to thicken the thin fibrous cap on top of lipid-rich lesions. We can also do that, at least experimentally, by putting in a stent. And if you put a stent in, it invokes a certain amount of neointima. And that neointimal coverage will actually create a new fibrous cap, or what we call a neocap, which can actually thicken the old thin fibrous cap. But is it safe to stent these vulnerable plaques? Well, obviously, we would need randomized trials. There's been a lot of preliminary work done, especially with bioresorbable scaffolds and metallic drug-eluting stents. And you can see when you stent plaques, you get over 6 months and then 24 months new coverage that can take a thin cap and thicken the cap, about 150 to 200 microns. We know that we can take lesions that have very high wall stress And we know that's a risk factor for atherosclerosis progression in the low areas of wall stress for plaque rupture as well. And by creating that neocap, it stabilizes the wall stress and equalizes across the lesion. And bioresorbable scaffolds are particularly attractive in this application because not only do they create the neocap, but then they allow the lumen to continue to enlarge over time. So we've designed a study within Prospect 2 called the Prospect Absorb randomized trial. And within the 900 patients that we've enrolled in Prospect 2, we're randomizing up to 300 patients with a lesion that's at least 65% plaque burden, which in and of itself induces high risk. And we're randomizing those lesions to an absorbed bioresorbable scaffold versus medical therapy alone. And all of those patients are undergoing routine follow-up imaging in 2 years to see if safely we can enlarge the plaque lumens and thicken the fibrous cap. And once again, we finished that study, and the Prospect Absorb randomized trial will be presented at TCT within a few days. So please pay attention. There's one other study going on of the interventional treatment of vulnerable plaque, which is a larger study, 1,600 patients in South Korea, where they're taking vulnerable patients and vulnerable lesions and then randomizing them to either a stent or a scaffold versus medical therapy. And this trial has enrolled about half its patients. So I'll close with this slide. Should we treat these lesions? This was a 65-year-old man who presented in clinical practice. He had exertional dyspnea. He was a prior smoker. He had hypertension and hypercholesterolemia. He had a pretty low LDL already on atorvastatin. He had a stress test which showed 1 millimeter of exertional ST depression, but normal resting and stress ejection fraction. So kind of borderline for ischemia. So his doctor recommended an angiogram, and here's his angiogram. And he had a mild stenosis in his LAD, proximally, a mild stenosis in his mid-LAD, and no other lesions anywhere else in his coronary tree. So the doctor did an FFR to see if this was an ischemia-producing lesion because of this borderline stress test, and the FFR was 0.88. So there's no ischemia in the LAD. He then wanted to characterize these lesions, so he performed near-infrared spectroscopy and intravascular ultrasound. And both of these lesions were very lipid-rich, anywhere from 36% to 57% lipid-rich, and they both had high plaque burden, 71 to 74%. But you can see how mild this looks. So the patient was already on high-dose atorvastatin and already had a low LDL. So what should we do for this patient? Should we put him on a PCSK9 inhibitor, or should we stent these lesions? So I think we would not stent these lesions today. Today, this patient was treated with a PCSK9 inhibitor, which again has a very low side effect profile, and his LDL was brought down below 30. But once we see the results of Prospect 2 and the PREVENT randomized trial, maybe we'll be considering the prophylactic interventional treatment of vulnerable plaques in the future. Thanks very much.